Yo, what's good, fam? Hey, welcome to another video on the community for contemplative conversations. And today we got a good guest with us, baby. Dr. Lenwood Hayman. He's a professor of public health at Morgan State. He's going to talk to us a little bit about social determinants of health. This video is broken down into two parts, so there's going to be a part two to this in a little bit. But the first part, he's just going to rock with us and tell us a little bit about social determinants of health, what they are, and get a little bit about who he is. Stick around. It's great. It's a lot of fun. Really energetic. Very informative. And if y'all know Lenwood, that he bring that fire. Fire. So, thanks for joining us again. And stay tuned.
Lenwood, hey brother, brother Lenwood, me, we go back like four fast on the Cadillac, man. So
Yeah,
look,
with
man,
the white walls.
white walls it is, bro. Hey, we can't get it that today. We try to be professional. Hey, but hey man, tell these people who you is, man. Lenwood, tell them a little bit about your background, where you at these days, and what you do, man.
Yes, sir. Yeah, my name is Lenwood Hayman. I am trained as a psychologist, trained as a social psychologist specifically. Even more specifically, I'm trained as a social health psychologist. My PhD is in social health psychology from Wayne State University. And what social health psychology basically means is I'm trained in all of the social ways that make people sick. And so what that's talking about is like the various social categories that lead to people getting treated a specific way that end up making them sick. And make no mistake, when I'm talking about people, I'm talking in generally about black and brown people in the United States. I'm talking about marginalized people. I'm talking about devalued people. Talking about persons of color. Um, I am an associate professor of what's the school I'm in? The School of Community Health and Policy at Morgan State University. So I was a little bit confused because I just finished up my first year there, and as y'all know, as you know, the once COVID hit, like it cut the second half of the second semester like in two, and so the rest of my first year, the last 25% of my first year is like a blur because of having to scramble to get everything online and whatnot. So I'm still trying to get the acronyms and the names of the schools and all this stuff. I can't remember all this stuff, man.
Hey man, it's all love, man. It's all love. Hey, but at least you remember where you work at.
Hey,
That's all that matters.
hey, if I'm gonna be for real, the main reason I remember where I work is because I went to school there. Otherwise, I might have some trouble, man. Don't
Hey,
let me be in some
the
obscure college.
HBCU life, baby. The
No
HBCU
doubt.
life. Pull up, pull up. Hey, so Linwood, so most of your work has been in public health and that kind of arena, and you did this talk that I got the pleasure of going to a little bit over a year ago, where you talked about a little bit about this social determinants of health.
Yes, sir.
And so talk to me a little bit about your work and about these social determinants of health. And then how do you think that's kind of playing out in today with COVID, a lot with the George Floyd? There's a whole lot more that goes to it, but tell the people a little bit about the social determinants and how you see that playing out today.
Right on. But when we think about social determinants of health, usually when we think about health, we think about biological or genetic determinants of health, physiological determinants of health. When we talk about social determinants of health, what we're talking about are straight up social categories that contribute to people getting sicker more often, getting dying, quote unquote, prematurely. Social determinants of health are the biggest contributing factors to the disparate rates of morbidity. In other words, acquiring illnesses like hypertension, diabetes, heart disease, obesity, alcoholism, and now COVID-19. It's the social determinants are the categories that contributed to Black people dying, contracting and dying more, disproportionately more than white people from these particular illnesses and diseases, right? So when you think about social determinants, it's, you know, absolutely positively race and ethnicity. These are social categories. They're not, they, we were, initially we were led to believe that race was dependent upon biological outcomes or biological factors, genetic factors. But by and large, what we found is that Black and white people, or people across races, are more similar than they are different. And something like race is based on a phenotypic difference. So that's just based on something that we can see. It's not necessarily based on, it's not based on a significant amount of biological or genetic factors that that would really account for the disproportionate rates that Black people die and that Black people, you know, acquire these illnesses. The main way that social determinants of health work is via stress. So when folks are in a specific category, well, basically when folks are Black in the United States, when folks are indigenous peoples, First Nation peoples, Native American peoples, the way that we have been treated across time is stressful because we've been led to believe that we are, what is it, 1/5 the people that white people are. We've been led to believe that we are not, that we should not have access to certain resources, even once segregation was ended, even once Jim Crow was officially ended. Social determinants came into effect because Caucasian Americans had roughly a 300-year head start.
300.
Even Usain Bolt can't recover a 300 damn year head start, bro. Caucasians, European Americans basically had a 300-year head start on African Americans, on Black and brown people living in the United States in terms of the acquisition of wealth, in terms of the acquisition of property. And generally what that led to is much like what took place on plantations, African Americans got leftovers. So whatever Caucasians didn't want, that was what, you know, African Americans were allowed to have. Now, the reason that we call these social determinants of health is, again, they don't have anything to do with biological differences. They don't have anything to do with genetic differences. So these social factors that I'm talking about are income, financial income. I'm talking about holding land, property. I'm talking about owning homes, houses. I'm talking about diversified stock portfolios. I'm talking about generational wealth. Generational wealth is a heck of a buffer. Generational wealth is a heck of a buffer to run-of-the-mill stressors that take place in the rat race, right? So what we're talking about is, no, it's not that white people don't experience similar stressors when they work. It's that they have enough of a buffer to not experience the stress that African Americans experience for the same amount of time, right? So if they were to Caucasians at the upper end of the socioeconomic status, they could experience job loss. But because of their generational wealth, if they lost their job, they will have more time away from separating them from actually going homeless or actually going hungry than they would if they were at the lower end of the socioeconomic status, right? African Americans are disproportionately representative of the low income and lower middle income status than are white people. Again, not because of African Americans aren't smart, not because African Americans can't, do the same jobs, if not better jobs than do white people, is that they haven't had access, to the same types of resources that Caucasians have. So when they experience stress, it hits them a lot harder because they don't have that same kind of financial buffer. When they lose their job, they have a disproportionately shorter amount of time that it would take them to become homeless, that would take them so that they wouldn't have access to food. African Americans live disproportionately more often in places that we call food deserts, places where there aren't full service grocery stores, places where there are far more fast food and convenience shops, party stores in their neighborhoods, liquor stores in their neighborhoods that sell low quality food. If you combine chronic stress, frequent experiences with stress, having little escape or little solace from stress, little sanctuary from stress with a bad diet, that's a perfect storm for negative health outcomes. What I studied for my dissertation was the feeding behaviors of low income women, low income parents for their preschool-aged children. And when even though I was studying low income, I didn't look specifically at any race, but it was disproportionately African American. Most of the sample was African American, again because of that correlation with race and socioeconomic status in the United States. Basically, the long and short of it, what I found was that a lot of the social determinants, or a lot of the social factors that determine health outcomes in the parents, in the mothers specifically, they were already en route to setting up those very same determinants of health outcomes in their children. What I mean by that is there are studies that show that doctors, physicians, actually believe that African Americans don't experience pain at the same rate that Caucasians do. So when they go to the doctor, when they go to ERs, when they go to get treated for certain illnesses, specifically for major illnesses, their pain isn't regarded in the same way. They say, "Oh well, I hear you saying that you're in pain, but we're not going to assign you the medication," or they'll assign them a significantly lower dose of medication, prescribe them, I should say, a significantly lower dose of medication than they do their Caucasian patients. What we see playing out, and basically what that translates to, is a dismissal of their experience, a dismissal of their pain experience. It's we hear you saying that you're in pain. We hear you saying that you are experiencing stress because of this specific experience that you've had, but we don't believe you. Plain and simple. So what was happening in their kids was parents actually said that, well, what do kids have to be stressed about? Again, they low income, they living in the same doggone household that their parents living in. The parents stressed out, but the parents don't think that the kids are actually picking up on the stress, right? So what they were doing was they were socializing their children to believe that the stress that they are experiencing is invalid. What do you have to be stressed out about? Meanwhile, they would talk about, how their kids would have emotional outbursts frequently, how their kids would, cry and be sad and be upset. All of these things are indicators of stress, right? All of these things are indicators of somebody suffering from chronic stress, but yet and still, they weren't validated by their parents. You know what I'm saying? So when I ultimately ended up, shifting over into resilience work, resilience framework, a resiliency-based framework. Um, my primary reason for doing that is because, all right, so we know that we know that families, low-income families, are having a hard time um, coping amongst themselves with the experience of being poor in the United States. This ain't even, bringing race into it, but this just being poor in the United States, right? Um, and because of that, it increased the likelihood that they would teach their children to believe that if you work hard enough, the stress that you experience en route to having a life where you can survive, not thrive, but a life where you can survive in the United States, the stress is worth it. To me, it just don't sound. It sounds it did something to me, man. Like
Mm.
it really did something to me to interview 70 some mothers. And now, granted, this wasn't a representative sample like a nationwide, so I can't, I want to make sure to not suggest that the findings from my studies could generalize to the broader United States. But I ain't no slouch. We do the literature review, we see the
Right.
same trends, right? We see the same trends. There's evidence to suggest that the same trends take place across the United States. So ultimately, it just got to be, it was depressing, and that I wasn't motivated to, to do the work. I wasn't motivated to have yet another interview or focus group and to hear, more of this bad news. And because of the model, it wasn't it wasn't an intervention. It was an interview and a focus group. So I'm only collecting information from them. I'm collecting their stories. It's not like I had the opportunity to say, all right, well, this is what you do, this is what you do, and actually enroll them in a specific program. So what I'm interested in doing now, what I'm doing now is helping African Americans, Black and Brown people, people who are distanced from their resiliency, helping them to realize, first things first, just how resilient they are to even survive in the conditions they've been surviving under. But then to help them flip that and say, all right, if you face this and you survive this, if we just flip a little bit of this and flip a little bit of that, I think we can get you to thriving.
Mm.
And what that basically means is survival is from one generation to the next, there's lateral movement financially, socioeconomically. There's lateral movement. Thriving means from generation to generation, you're going up, right?
Right.
That's what got me into mindfulness, contemplative practices, and all that.
And hear you talk, just I don't think people understand the magnitude of how your zip code literally in this country determines a whole lot about your outcomes, right? And I think this will lead us to the next part is that, especially when you think about in COVID, right? We have, schools who, have to now go to these virtual settings, universities, you can name them, daycares, whatever, that have now moved into this virtual setting. But your zip code in this country determines how good your connectivity is to the internet and what your capability is to get the internet. You can literally call your internet and say, "Oh, I want to get y'all." Y'all have these nice commercials that you can get the 100 speed internet. You
Yeah,
can call and say, "Hey, can I get the 100 speed internet?" Well, in your
absolutely.
neighborhood, you only can go up to 65. You're like, what? But I don't think people realize that your zip code, like literally in 2020,
Hands
determines
down.
a lot about what you can have access to just on a very accessible level.
Yes, it
That
is.
means how well your lights are bright in your house, how clean your water is, how your internet speed works. Like, I don't think people realize the magnitude of how much literally a zip code. and where you are, and most of that is built off just assumptions about who lives in those neighborhoods, right? Now, that isn't to say that all people, because again, we have a skewed view about what poor people look like in this country too, because as you noted, it's not just black and brown folk. There are poor people who of a diverse group of folks, right?
It is. Yes,
But
there are.
but at the end of the day, I think there's a disproportionate when you look at population wise, where black people end up being in that group a lot more often, just because of percentages of to the larger population. So
Yes.
so with that being said, how do you think these social determinants are playing out kind of in this COVID spirit that we're having right now? How you see that playing out from your experience?
Yes, sir. Well, a lot of the recommendations that were made, for example, social distancing, staying 6 feet away from people that you don't live with. How can you stay 6 feet away from somebody when you live in the housing projects and you live on top of each other, real close, bunched into somebody else? Now, somebody might say, "Well, just stay in the house." All right. Well, if you just stay in the apartment, then why would you want to stay in the apartment when the apartment has holes in the walls and in the roofs, when the apartment has very, like you mentioned, issues with the water running, issues with the electricity and the lights in the apartment, pest control issues, right? Why would you want to stay in that place now that it's getting warmer outside, right? You don't have air conditioning in your unit, so it's actually cooler outside than it is inside your unit, right? Why would you want to stay confined in this small space? How could you want to stay confined in this small space? A colleague of mine, one of my new colleagues, she already the greatest to me. She my mentor already. I told her this. I think it was the first week I told Dr. Edwards. I was like, "Dr. Edwards, you my mentor now." She was like, "Oh, you funny, Dr." I was like, "You think I'm joking? I'm being dead serious."
Right.
She came up with this thing called the perceived risk hierarchy theory. She has patented it. This sister has patented it, and she is she is positioning herself to be in a place. She's an academic entrepreneur. You don't really hear about that very often. An academic entrepreneur. I know I'm getting a little bit off track, but I promise you I'm gonna make it fit. The basic premise is that Maslow has his hierarchy of needs, right? You can't focus on what you're going to wear to work if you don't have breakfast, or it's very difficult for you to focus on higher order cognitive actual cognitions, thinking processes, when you don't have your basic needs met, right? The perceived risk hierarchy theory is based on that same premise, where I can't worry about COVID-19 when I live in an area that has high violence, or I'm living in an area, as I mentioned, where it's very, very difficult to actually stay inside, right? To quarantine or to stay away from people. If I have symptoms, right? Talking about COVID-19 and how social determinants of health influence COVID-19 outcomes. If I have symptoms, depending on the zip code in which I live, as you pointed out, the hospitals in those zip codes, or the hospitals assigned to those zip codes, are woefully under prepared, under equipped, poorly resourced to be able to deal with, to provide ventilators, even to provide, just basic treatment. What happens when someone gets sick is when they start to feel symptoms, they have to make a decision. All right, so am I going to go to the hospital, or am I not going to go to the hospital? Social determinants of health and the perceived risk hierarchy theory come into play when my social determinants have made it more likely for me to live in a zip code that is under-resourced, right? An area code, I should say, zip code that is under-resourced, right? The hospital, if there is a hospital close to me, is under-resourced. I don't go to the hospital anyway because I don't have insurance, which is also a social determinant of health. If I go to the hospital, chances are I'm not going to get the type of treatment that I really want, because as I mentioned earlier, the doctors don't really see me as human and having a human level of pain. They see me as a subhuman, but having a superhuman amount of pain, or a superhuman tolerance of pain. So they're not going to give me what I need. That's taken into consideration that the hospitals even have what I need, right, in order to help me feel better. I have historically been trained to believe this and understand this about the healthcare system in my neighborhood because of the social determinants of health. So when I'm perceiving the risk of actually contracting and dying from COVID-19, I'm like, all right, do I really have the time and the energy to go down here to this hospital to then be discriminated against, obviously, by saying, no, we don't have what you need, we're going to turn you away, we're just not going to treat you, or be discriminated against systematically by going to the hospital and them saying, we would love to treat you, we know we need to treat you, but again, we don't have what you need, right? So one way or the other, they're not getting what they need. So their perception of risk is that, well, shucks, I'm just going to stay home, right? It's easier for me to stay home and try to ride this joint out the way I ride everything else out than it is to actually go to the hospital or go to, somewhere and get treated from this. Now, what we're seeing actually happen from what we see actually happening from COVID-19, those social determinants of health and the stress associated with those social determinants of health contributed to those very health outcomes that COVID-19 loves to consume, right? So if you got any type of pre-existing condition, COVID-19 is like, yeah, buddy, that is delicious. So I can't wait. Here I come. I'm coming to get you first, right? That's why African Americans, indigenous peoples, First Nation peoples, Native Americans, that's why they have been dying at such a higher rate, a disproportionately higher rate. They haven't been dying more, right? There hasn't been a higher number of African Americans and First Nation peoples that have died from COVID-19, but in terms of the proportion of in terms of the percentage that they make of the United States population, they've been way more. There have been, way, above and beyond number wise. There's been way more Caucasians that have died from COVID-19, that have contracted and died from COVID-19 than any other group. But what we are also seeing is that the Caucasians that are dying, not necessarily contracting, but the Caucasians that are dying from COVID-19 are facing those very same health outcomes that African Americans and First Nation peoples face. They're overweight or obese. They have pre-existing conditions such as diabetes, such as hypertension, such as heart disease. All of these things, they've been smokers. All of brothers and sisters in West Virginia that have worked in coal mines, that have the compromised lungs, they have died more frequently. All of these things that are also social determinants of health take place in white people too.
Right.
Very same thing taking place in white people too. So that's how COVID-19 has really been able to run rampant in low income, whether it be rural or urban low income, African Americans, First Nation people, Native American peoples. They've been fighting against the history of, or historical contributing factors of um, uh, uh, their race that put them in this specific, that increased the likelihood of them being in this specific socioeconomic status. There are other Caucasian brothers and sisters who were just left behind by capitalism, who are still chasing the American dream, who also, by means of social determinants of health, ended up dying, or are dying more often than Caucasians at the upper end of the socioeconomic spectrum.
Brother, you want to know what makes most of this frustrating about what you just said, and some of the things you named, with being able to go to a hospital, or the time and energy to decide if I'm going to actually go to my job and survive instead
Yeah,
of going to the doctor, is that 95% of this is preventable
yeah,
by providing affordable health care, or Medicare for all, whatever you want to say, adequate amount of, of salary or hourly compensation at jobs that, I may have now, as you mentioned earlier, a bigger buffer that I can take a day off to be able to have time to go to a doctor. But because I only making 8.50 an hour,
yeah.
I can't take that risk, right? So then you're saying, well, which risk is worse than the other? Am I going to put food on my table, or go to the doctor to have COVID, to maybe be treated? That now people are really deciding between the fact of, am I going to go to work every day, or am I really going to go get myself, like, my actual well-being, cared for? And those are the things that people are really jockeying it with. But then at the end of the day, it's just all preventable.
Yep. Yes, sir.
Like,
Yes, sir. The,
95
but
is preventable.
the great the crazy part, and you gotta laugh to keep from crying, as old folk used to say. But the crazy thing is, right, when the job knocks happen, like when the layoffs started to happen, yes, it impacted African Americans a lot more, right? I just read this morning that um, over half of African Americans in the United States are now unemployed. Over half, bro. Over half. Just before, it was 60. Was it 60% of African Americans were gainfully employed? So I'm talking about, and I think I'm adding in the gainfully part,
Right.
right? So you mean to tell me that the unemployment rate was 40% in the African American community, when you take into consideration rates of incarceration, when you take into consideration the type of jobs that they work in, when you take into consideration the pre-existing conditions that preclude them from working, when you take into consideration they don't have the education, they don't have access, I should say, to the education the same way that some other Americans might be privileged enough to get education. They don't have the training. They were already underemployed, right?
Right.
And now the employment rate is 50%. But when the layoffs started to happen, there were actually some who was like, praise Black Jesus, I still got a job,
Right. Right.
right?
Right.
Just so happened, it might be, I got my little job at Giant, or what we got, the shop right here, the grocery stores, these jobs that have now become, frontline workers. Um, uh, and like you mentioned, they have to decide, all right, I need to go to work. I know a lot of people that have lost their job. I might be living with people that lost their job. So now my income is the sole income for the whole house. So I gotta go to work. And now that I'm going to work, like you mentioned, I'm increasing the likelihood that I'm gonna be exposed to this illness, especially in the early days before they had the, little plexiglass screens put up
Right.
and the lines and whatnot in the stores and whatnot. So they taking this chance, they taking this risk in going to work because they don't have a choice. We just had something published. It was Dr. Edwards, the professor that I mentioned to you, myself, and the chair of my department, Dr. Randolph Rao. Maurice Edwards is the Dr. Edwards that I'm speaking of. We just had something published in the newspaper. We kept trying to get that junk published, in a journal. We even tried to get it published as a blog, man, but they wasn't checking for it for whatever reason. So we ended up having to get it published in the newspaper. And the basic stories, real short story, is published in the Baltimore Times, is it? Yeah. The short story is I am evaluating if I'm gonna go to work or if I'm gonna get sick. And if I'm sick, I'm evaluating, am I gonna stay home and lose my job, or am I gonna go to work and get sicker, get some other folks sick at work, right? So when you talk about prevention, being in public health, it is so incredibly frustrating to think about how easy it is to actually prevent the outspread, the spread of this disease by practicing very, very simple things that were not in place prior to the disease. So when we look at why the disease was able to run as crazy, look, you remember Bebe's Kids, man? Am I dating myself?
Yeah, brother, Bebe's Kid, fire. I was just
Yo,
fire, bro. Still to this day, you watch
yo,
episode.
Robin he was a bad man. He was highly underrated comic, man. I can't remember his last name. Robin, dang, I won't remember. It ain't germane to what we talk about. But at the end of the day, the reason I bring up Baby's Kids because they was wild. They was crazy. They were showing off. That's how COVID-19 is running wild out here right now because COVID-19 ain't got no damn home training.
No,
You know what I'm saying? COVID-19 is like, listen, I'm coming up in your place. I'm gonna put my feet up. I'm like Rick James in Charlie Murphy's sketches
right.
in the Chappelle Show, man. Bump your couch and put my feet up on your couch. I'm spreading my joint everywhere. I don't really care what you got going on. If you ain't gonna get sick, I'm gonna hang out with you long enough so I can meet your folk, and then I'm gonna get them sick because I know where you live. You can't get away from people.
No,
And not only can you not get away from people, you can't go somewhere to get rid of me. So I'm gonna hang out with you as long as I damn want to. And I know you ain't gonna be wearing no masks because PPE, man, let's not even talk about personal protective equipment. The doggone hospitals ain't got PPE. So how you figure that the people in the neighborhoods actually gonna have PPE in order to, prevent, being sick? If they ain't getting it from work, then they ain't getting it. But the point that I'm trying to make is, man, all of these things that you mentioned, you was gracious, man. You said 95%. I might even say 97, 98, maybe even 99% preventable, man, because none of this had to happen. The disease did not have to run as rampantly as it did in the United States. Even taking the administration's response out of it to a certain extent, right? All right, so they waited, a long time because for whatever reason, what reason, but for whatever reason, if there were systems in place, we see it happening in Canada right now. If there were systems in place, if there were preventative systems in place, the disease will not be allowed to run around as rampantly as it is. Just as an indication as to the two different Americas we're living in. or how COVID is treating America, the two different Americas. There are two different Americas, and COVID-19's influence in these different Americas is vastly different. My wife, as you know, works in the hospital. She works at Johns Hopkins Healthcare down here in Baltimore. She works at the main campus. So she sees, rich people, and she also sees poor people, because what a lot of people don't know, Johns Hopkins is actually in the hood. It's actually like in the hood. They doing their best to buy up a lot of the property around there, but Johns Hopkins is in the hood. Matter of fact, it's so much in the hood that the dude that is the pioneer of the zip code work, Anthony Iton,
Okay.
he got the idea for doing the zip code work. This brother is Canadian. It's a black dude. This brother is Canadian. He came to school at Johns Hopkins. He came outside of John. He said he was there on an interview or something like that. Like he hadn't even come to school there. He hadn't even started in school there yet. He comes outside of the hospital and he looks around and he says, "Man, it looks like a war zone." When you look at the houses and the homes that were in disrepair, when you look at the people that were meandering around as if they had, just wandered out of a building that had been bombed, he said it amazed him, and that gave him the idea of, but wait, I'm staying in this part of Baltimore County. Right now, I'm in Baltimore City. Baltimore County and Baltimore City, the main things that they have different are zip codes, right? So, what is it that's going on in this zip code that's got it looking like a doggone war zone that's different from this zip code where they have all the amenities that they need? So, this is how this brother actually got this idea, because Johns Hopkins is in the hood. Ain't that something? But anyway, Alexandra works in the hospital. She works there. She's a physical therapist. And so it's interesting because her very job is to get people, she is an acute care physical therapist. So basically what this means is, before COVID-19 took place, her unit was called the MICU, the Medical Intensive Care Unit. And what that means is these are folk that come in with really, really significant illnesses, and they have a strong chance of survival. That's why she goes to see them. But the significance of this unit is that they are trained to get people up after significant extensive surgeries as quickly as possible, even with the vents, even with all the tubes and whatnot hooked up to them, because study after study, data after data is demonstrating that the faster you get somebody up and moving, the not only the more mobility they'll be able to regain, once they get out of the hospital, the higher the likelihood that they will survive longer, right? So her unit was the first unit to get to get transitioned into a COVID unit. So they got I can't remember how many beds that she said that they have in their unit, but her unit was packed first, right? And so when she was going in there, some of the things that she would have to do is basic stuff like moving people's arms, moving people's legs, helping the doctors and the nurses put people on their side so they can breathe, put people on their stomachs so that they can breathe, even while they hooked up to the vent, like all of these things to increase the likelihood of them being able to move. So she had, these instances where she had this 80-some-year-old white lady from New York, and I'm talking about Manhattan. Her apartment overlooked what's it called, Central Park. So you know what kind of bread this lady has, bro, has. She 80-something years old, doc, contracted coronavirus and lived. 80-something year old. Anybody else 80-something year old, when you get coronavirus,
Not happening.
it's a wrap. You better, write your junk down. You
Right.
better hope you got your shit written down before, because
That's it.
likelihood of you coming out, that's one bed. Another bed, she had a brother, late 30s, used to play football, linebacker, works as a social worker in Baltimore, Baltimore City, that is. When he got sick, he got real sick, like real sick. Like, he was one of the cases that they didn't really think he was gonna make it. Now, he ended up surviving, but he got so sick that it was really, really touch and go there for a while. Now, when you think of this story, the reason to me that is so amazing, and the reason that I think is indicative of the two Americas that exist under these letters of the USA. We have one woman coming from like upper class, and she didn't 80 years old and did not get half as sick as this brother did, who had COVID-19, right? He was on death's door. She was not chilling, but she wasn't as sick, right? Now, how is it that this 80-some-year-old lady was able to have this experience with COVID-19? A late 30s athlete, dude was still active, still exercise, still, wasn't a weightlifter, but he still, participated in his physical activities and everything like that. This dude was on death's door. 39 versus 80. She lived half as long, twice as long as this dude did, but yet he got twice as sick as she did.
Mm-hmm.
The difference, the main difference, income. When we talk about social determinants of health, the experiences that she has had being white in the United States and having the income that she had afforded her a buffer, an internal buffer within her system that allowed her system to be so much hardier in fighting COVID-19 than did this brother's system. From being, I don't know what his socioeconomic status was. She, thankfully she didn't break HIPAA and telling me what she did. She didn't tell me like their names or anything like that. But at the end of the day, knowing their races and knowing their socioeconomic status, no, this is not evidence to demonstrate exactly how social determinants of health are dividing the United States, but it definitely suggests, I'll call it anecdotal evidence, that's fine, but it definitely suggests that these are two grossly different experiences that people are having. Chances are, now that this brother has had COVID, he will not make 80. He will not see 80. Because of the what studies are now showing is that people's lungs after you have it are still compromised. Like, you don't have the same lung capacity that you did before you actually had the disease. So the likelihood of this brother still being able to participate in physical activity at the level that he was is now lessened significantly because he had COVID-19. And what we know about people that do not engage in physical activity is that they have a shorter lifespan. So this lady at 80 has already won. She survived. She contracted and survived COVID-19 and, living.
Right.
I don't know if she's back in her apartment or not, but she's somewhere straight. This brother, contracted the illness, not even 40. The likelihood of him making it to 80 is now, I don't know what the rate is, but it's lower now because he's had this disease. That's social determinants working on you.
Hey, you want to, and we just keeping it 100. We family.
Yeah.
The worst part of it is the average black man in America lived about 63.
Come on, man. Already.
Oh, wait. So you talk about 80 was being real generous.
Yeah.
I feel that he could even make it to 50.
Come on, man. Come
Again,
on.
people, and I think what you said before we wrap this up with another question, I think what you said is really important is that when you start to peel back the layers of all of these things, there's another story there. Like, because we really think about the fact in the US, and I'll talk about two things you said. One is about the age in which people live to. When you start to peel it back about who lives until 80, who lives until 82, they have a very distinct skin color together,
Yes,
right?
sir.
Right. But particularly African American men on average live about 63.
Yes, sir.
63 to 82 is a lot of years, right?
Come on,
But
man.
we don't, but again, we only talk about averages. But I think the one thing that my graduate experience taught me is that what doesn't the data tell you, right? We only
Mhm.
high level
Mhm.
kind of aspect of this is 82. Oh, everybody lives to 82. Nah, not everyone. The majority, right? But when you start to peel it back, right? Another aspect of what you said is when you start to look at this thing about unemployment, right? And about how we actually determine what unemployment actually means. Like on the general sense, yeah, 15% of people don't have a job. But when you start to pull that back and then you start to like how we define what unemployment means, then the numbers start to look very drastically different. But again, we don't look at like what we consider to be unemployment, which is somewhere hovering at like the 14, 15%. But even still, in the last 2 days, we didn't find out there was a miscalculation, right, of data, right?
Come
And
on, man.
'cause I ain't gonna lie to you, Lenwood. As soon as I saw, I woke up, brother. I know when them job reports come out. Now, I said to myself, I said 13%. I said it's something a little iffy about
Don't
13%.
even sound right.
Ain't no way that the jobs go down
No.
based on what we've been seeing. It ain't no way possible. Now, and again, I hope and I pray that people get their jobs back. Like so I don't want it to sound like I don't want people to get their job back.
Yes, sir.
But at the end of the day, there was no way possible about what we've known over literally the last 5 weeks that the job report could go down. Maybe slightly, but not 3 percentage points. That means a whole lot of people got their jobs back. And now what we're finding out 48 hours later, well, they didn't get their job back. That it was a little error that we had because we didn't calculate it in the same way, right? Like people are absent from their job. And not because they on vacation.
Right.
People are absent, they on vacation doing COVID, right?
Exactly.
We don't get into the details about what absent from your job means.
Yeah. Yeah.
We took the definition about what was absent, vacation, maternity leave, and we're like, oh, all these people that's not working from COVID, they just absent from their job. But why are they not getting a check?
Yeah.
You on maternity leave, you on vacation, you still getting a check. But these folks not getting no check. They are absent from their job. But all of a sudden we say, oh well, look at the unemployment. It went down 3% out here. Boy,
Come on,
boy,
man.
the question is always, I think, this side note here for this whole conversation is that I think oftentimes, that again, I appreciate my graduate education teaching me, well, what doesn't the data tell you? Because we get very distracted by what is actually there. But what
Yes, sir.
happens when you start to peel that back, right? And and I think part of that has to do with like we as humans just get stuck on what is in front of us. Like we're right here. Well, it says 14%, but we don't do enough diving, and we also don't make information accessible enough for people to go find out what the true numbers really read, right? Because when truth comes out, some things start to change, and
Mhm.
but it's just fascinating, right? That when you look at these kind of when you start to dive deeper into COVID, or you dive deeper into unemployment, or you dive deeper into who has what access to internet, it tells a totally different story than the kind of what we're fed, like in the very kind of nature of news. It's just kind of surface level, like, oh, 14% of people, unemployed. But when you peel that back, you start about, well, who isn't unemployed? Because again, we lose sight that there are 300 million folks in the U.S. Now there are some of them who are young, so they can't go to work. I get that. But you take them out of the picture and then you just look at the people who are unemployed and you start to peel back them numbers. Woo, and again, it'll put a lot of these notions around pull yourself up by the bootstraps. It'll tear
Man,
all that down to the ground because
come on, man.
you can't pull yourself up by the bootstraps. Well, matter of fact, you don't even know where the boot's at. Not that the fact that
Exactly.
you don't even know where they at. It's not the fact that you don't even have strings. You don't even know where the boot's at.
Got them
You,
damn boots. And
oh,
the thing that got me, man, was when I realized that the unemployment rate is based on folk that file for unemployment. So imagine all of the folk that don't file. Like you said, when you peel back that junk and you realize, like, dang, it's all these people that don't even file unemployment no more.
because again, you got to be able to get to the place to file unemployment.
Hello? Hello?
If I ain't getting there, I ain't going.
Hello?
Right? Because again, it's just a system, and we go braid it back to the past. But you know how we get off topic and start ranting and raving sometimes. But at the end of the day, it goes back to what you said earlier, that when you are living in a house with 9 other people and that income is helping us to basically survive, not necessarily thrive, then yeah, I may not need to go to the unemployment office, is because Aunt Teresa's salary from Giant is gonna get us through the next few months, right?
Yep.
And then all of a
Yep.
sudden, and we're loving people for the most part. And so therefore we don't really, you know, you know, encourage those that, hey, go file for unemployment, because again, we are resilient people, so we're like, well, we got it. But again, that causes more stress. Things
Yep.
like COVID show up. Then all of a sudden we get much sicker because of these things that are happening. Now, ain't no ill on people who can't get to the unemployment place, but it then shows the bigger issue we have in our society about not creating accessible things. And again, when it is accessible, then you got to worry about your internet connection, because your zip code don't allow you to have the best, and it's just like,
Yes, sir.
hey, like we could make all this disappear if we really wanted to. But
Mhm.
again, we promote this idea of scarcity in our country, but
Mm.
scarcity, they're gonna have to be a topic for another day of the week. But scarcity
Mm.
really does exist, because somehow, we done had 5 wars in the last 20 years, and ain't nobody asked about where that cash came from.
Come
But
on, man.
I digress, brother. So, went to my old Southern preaching ways out here. Get that communion plate out.
All right, folks. And I hope y'all just went right on over to the second video, part 2, Brother Lenwood. So in this section, he's going to give us a little bit about some of those practical things like we can use to think about these social determinants of health and how we can actually implement them in our own life. So again, check this out. This is more fire.